So thank you everybody for joining today on this lovely sunny lunchtime. I really appreciate you taking the time to come and learn about eating disorders with me today. So the session is being recorded and will be uploaded onto the YouTube channel. Today I'm going to talk about eating disorders. Now, my background is that I'm a paediatrician, but I've got an interest in young people's health. And during my role in the past year, I've had the opportunity to work with the community eating disorders team. So this has given me a bit more of an insight into the kind of mental health side of managing eating disorders and how eating disorders are managed in the community, as well as more experience in working with young people with eating disorders who are admitted to hospital. So what I wanted to cover today it is really an introduction to eating disorders. So I hope by the end of the session you'll know when to ask yourself, could this be an eating disorder? We'll have a brief think about the differential diagnosis. I'm going to mention HEADS assessment, which I'm sure that you'll have heard of, and there's lots of really good resources out there about HEADS, and particularly from our Adolescent Health Week. But we're going to think about HEADS in the context of an eating disorder. And I'm going to run through some of the signs and symptoms of starvation. We're going to start the process of considering risk assessment in eating disorders, and then at the end we'll talk a little bit about how eating disorders are managed, both in the acute setting, inpatient admissions, and the community eating disorders service. Now, this is quite a big topic, so throughout this I want to give you lots of pointers as to where to look for more information. And the key bit of guidance that I want you to be aware of is the Junior Marzipan guidelines. So you may be in a setting where you're not working with children and young people with eating disorders very frequently. And so making sure that you, whenever you see a young person with an eating disorder, either a diagnosis or you have this in mind, you go to those guidelines and work through them. It will give you a really good picture in terms of that physical health and risk. So Junior Marzipan is where to look for the key information on eating disorders. Please feel free to pop any questions in the chat bar. Catherine, who's facilitating alongside me today, Catherine, if you think there's a relevant question in there and I've not responded, please pipe up and let me know. But otherwise, we'll go through. I'd like this to be interactive, so there's please do fill in your answers in the chat bar, or you can also speak by unmuting yourself. So we'd like it to be as interactive as possible. So I just wanted to start with a really fantastic piece of online learning that is relevant to any young person presenting in crisis to the hospital setting. And this includes young people with eating disorders. Now, this is the most amazing tool because it teaches you that even as a non-expert in mental health, you can really do small things that are really going to make a difference to that young person who's coming in at a time of crisis. It takes an hour, you can do it on your phone. But I think it's important that we think about the young people that we see when they're coming in crisis. There's just getting the basics right, being considerate, being compassionate, giving them a little bit of time and thought can really make a difference to their care. So please do check out the We Can Talk online learning. So I wanted to start with a case. So it's 5:30 a.m. and the triage nurse calls you. You've managed to get to your paediatric SHO, you've managed to get a little bit of a break from your night shift, so you have a little bit of a stretch and a yawn, and this is what the triage nurse tells you. So 15-year-old Lorraine has been brought to the emergency department because her mum found her vomiting and she was concerned that she had not been eating much recently. At triage, with her mum outside of the room, she discloses that she's taken 26 paracetamol tablets. Her background is that she's been known to CAMS She's had a previous overdose and is being treated for depression with sertraline. Her observations at triage are that her heart rate's 110, blood pressure 105/70 systolic, temperature of 36.4, and her weight is 40.3 kilos. She's sat in the waiting room with her mum and she's next to be seen. Can you assess her? So, what are you going to do? What will your approach be if you were the paediatric SHO or registrar and you got this call? Can you think of some pointers for what you would do if you were seeing this young person?
Can we speak, Emma? Or
Yes, please speak. Yeah.
Thank you very much. Like, it's really a worrying scenario because first of all, she has taken quite a big dose of paracetamol, and she has only disclosed to me. So that is my first thought. I will speak to her, like it's important for us to like treat her because of the reasons. I will let her know what are the reasons, and then obviously I need to involve her mom as well. But I will discuss with her first why I need to involve her mom, and let her know that her mom is there to support her as well.
So the kind of key, sorry.
Yeah, that's absolutely fine. Go ahead.
So the key pointers, that I would say are, yes, you need to see her alone in the first instance, but encourage her to disclose to her to her mum for that support. And you're right, that's a big dose of paracetamol. And if you look at her weight as well, she's quite a low weight, so that's going to be a high dose in milligrams per kilo. So you're probably going to need to start treatment. You're obviously going to need a lot more details about the overdose, when it was taken, etc. But that's going to be your priority in the first instance. But when could you think, could this be an eating disorder? So I wanted to give you a little bit of a kind of messy presentation, because not, young people don't come to the emergency department always with a label of, eating disorder or anorexia. So what are the features that might make you think about an eating disorder?
Emma, I have been called to recess, so I would allow somebody else to answer.
Thank you very much. Thanks for your contribution. Just some things that should make you think about an eating disorder. So if you've got low weight is obviously one key element. And you're going to want to think about low BMI. So you're going to want to think about calculating the BMI. Amenorrhea or pubertal delay is also something that you need to consider. But there are a variety of ways that a young person might present with an eating disorder. So it's not unusual for young people with eating disorders to also have, present with overdose, with self-harm. They may present with some physical symptoms, so with syncope, for example, or ankle edema. They may present with a history of reduced appetite, which they attribute to, for example, something like abdominal pain. So there's lots of different ways that a young person could present. And some of the behavioural indicators of eating disorders could include symptoms that may potentially be mistaken for depression. There was a study, the Minnesota study, that is a very old study, where they had healthy people who they subjected to starvation back in the days when you could ethically do that. And in that study, they found that there were significant changes in mood, increased irritability, withdrawal, obsessive and ritualized behaviors. So lots of and sometimes violence and rigidity around food. So when a young person is starving, they may present with a wide variety of different symptoms that may not at first appearance be feel like it fits. So it's important to ask the questions when you've got someone with a low weight who's presenting, for example, like this young person with an overdose. So the key features of eating disorders, So with anorexia, you have a young person with low weight, and we'll discuss the kind of the cutoffs and how we kind of how we look at weight in eating disorders. Evidence of physical compromise. You may get amenorrhea, but in some of our younger patients, they may not have started periods, and so you may have some pubertal delay. Young people will avoid food and or excessively exercise, purge, and this is driven by an underlying fear of fatness and body image distortion. So with bulimia, it's a similar picture, but there's more of the purging behaviour. With avoidant restrictive food intake disorder, this is where the restriction in intake is not driven by a fear of fatness and body image distortion, but is driven by other things. And then you have some young people who yes are a very low weight, but actually this is driven more by self-harm belief, by self-harm thinking, and some young people where their low weight is driven by a severe depression. If so, you're an A&E, you're not expected to come up with a full formulation of whether this is an eating disorder or not. But it's just important to be aware of some of those diagnostic features, because if you can pick out some of those things, you might not get all of those characteristics. It can help you in making a referral. And if something doesn't fit, so if you've got a young person with a low median BMI who categorically is saying that they do not have any kind of body image distortion or fear of fatness, those kind of beliefs, then it might make you think about potentially an organic cause. However, in the early stages of assessment, often you're going to find that young people are reluctant to share those thoughts, and so that's when your assessment with your eating disorder team really comes in handy. So what conditions could present with similar symptoms? So this is low weight, loss of appetite, potentially amenorrhea or pubertal delay. Any ideas? If we think about maybe some hypothyroid, yep, so that's great. So any other endocrine causes that we can quickly rule out? Yeah, fantastic. Yeah, lovely. So some great answers there. So these are the kind of major categories of other conditions that you don't want to miss. They could present with similar presentations to those that you find in an eating disorder. So celiac disease is one. Inflammatory bowel disease, you would expect to have some other symptoms and some derangement in your blood work. Peptic ulcer disease, another possibility, and then you've got your endocrine causes, so diabetes. You're going to really quickly be able to rule that out with a blood sugar test. Hypothyroid's been mentioned, glucocorticoid insufficiency, and then you've got your kind of oncological diagnosis that we all really worry about. But it's rare for these things to present solely with low weight and loss of appetite. And similarly with your chronic infections. So eating disorders are common. So whilst it's really important to think about our organic causes, we should be at the same time, not separately, at the same time also thinking about eating disorders with these patients. And if we can have a kind of dual approach, then that can be really the most beneficial thing for patients to get then the right help. So around 1% of 11 to 16-year-old girls have an eating disorder, and 1.6% of 17 to 19-year-olds, and with about 0.2% of 11 to 16-year-old males. So they are common, whereas a brain tumour presenting only with weight loss and loss of appetite would be rare. So this is HEADS. So HEADS is a tool that I've come to love over the past year. When HEADS is used well, it's an engagement tool. it lets the young person know that you are interested in them beyond their illness, beyond what's happening right now. And it's, you know, it just makes them feel, it can make young people feel really comfortable by asking them about, you know, home, education, activities, that kind of thing. And it gives you a full picture of the young person. So it can really help you to think about what are the risks for the young person, particularly when you're thinking about safety risks, suicide, self-harm risks, or any sexually risky behaviour. But it can also help you to think about protective and motivating factors, which can be really important. So heads, if you want to know more about heads, if you want more insight into that, then do have a look at the video by Dr. Steph Lamb from the Well Centre that is up on the London School of Paediatrics YouTube channel, because she runs through it in a lot of detail, together with some really useful public health data, and letting us know kind of how common these problems in these areas can be for young people. So what do you ask about eating? So food history is helpful, and you know, you may need to ask the mum, the parent and the young person separately, potentially to get a good idea about that. Does the young person have all their meals alone? So actually, do we not know what they're eating? Are there any kind of behavioural indicators, kind of secretive eating, or kind of aggressive or withdrawn behaviours when they're eating? Has there been any recent changes in appetite or diet? So with a lot of the young people that we see, we'll see kind of a progression from kind of healthy eating that then becomes more and more restrictive. Or for example, a young person who previously had a very varied diet and then becomes vegan, and then it kind of progresses on like that. So that can be a useful bit of information. So changes in appetite or diet. And you're going to want to ask the young person on their own about their worries about any weight or shape issues, and potentially also their parent, to see if they've noticed them, you know, getting the scales out more often, checking themselves in the mirror, etc. And then you're going to want to know about their exercise level. And the SCOFF questions can also be helpful as a screening tool. So they're highly sensitive and fairly specific as well. So these are also questions that you can ask about, eating to get a good picture of what's going on for the young person. But it's 5:30 in the morning and Lorraine does not want to talk to you. So this can often be be a problem. So if Lorraine doesn't want to speak to you, what can you do? Any suggestions of what you do in this situation?
I guess you still need to do a sort of risk assessment, probably using junior marzipan in the acute instance to decide whether or not she's safe enough, you know, whether for safety and risk reasons you need to admit her or not.
Yeah. So, I mean, for Lorraine, our kind of decision about admission's already been made because she's taken a significant paracetamol overdose, and that needs to be treated. Absolutely. So that makes things a little bit easier. Makes things a little bit easier. And you've also got her mum there, so that collateral history can be really helpful, and particularly if mum's noticed any kind of behavioural indicators that can point you in the right direction. And whilst whilst Lorraine may say she doesn't want to, be very withdrawn, not want to talk to you, she may because she's coming because she's been vomiting and she may be worried about her health. She may well consent to a physical assessment. I think it's what I've noticed and what can be quite tricky is if you've not been able to get like a nice thorough assessment in the emergency department, just highlighting that to colleagues as well, because it's 5:30 in the morning. I wouldn't really want to speak to anyone at 5:30 in the morning, but Lorraine may want to speak to someone a little bit later, and just making sure that we highlight that that we've not had that detailed one-to-one confidential conversation to really get to know her. Could that be something that's done later in the day, you know, when things have settled down a little bit for her? So making sure that that's handed over to colleagues, because you know you can't just keep pushing and pushing and pushing. You're not going to get very far, but you can, you know, if you can treat her medically, if various ways to think about that, examine her and just you know, let her know that you're recognizing that she doesn't want to speak to you and that she's finding things really difficult right now, and just being compassionate. So Lorraine doesn't want to talk to you, but she will consent to you examining her. So we're going to move on to physical assessment. So percentage BMI. So if everyone's got their phones ready, we've got a little bit of calculating to do. So the picture of Joey in all the coats is a reminder that when you weigh a young person, you need to make sure that they're not wearing blazers with loads of stuff in their pockets, they're not wearing all of Chandler's clothes, they're not wearing millions of coats, and that the shoes are off so that you've got an accurate weight. And we know that young people who have eating disorders will falsify their weight, so you want to weigh them in just light clothing. You're going to need you've already got the weights, that was 40.3 kilos, and you're going to need to check a height, and that's 163 centimeters. So how it's common, and we commonly look at risk in terms of as one of the factors being weight. We look at the median percentage BMI, and someone did mention that in the chat bar earlier. So this is median percentage BMI is the comparison of the BMI compared to the 50th centile, and that gives you a percentage number. So anything below 85% is worrying, but then the lower you get, it helps to score marzipan. So in terms of as Noreen's question is, why is it important to get a median percentage BMI? And I think that the answer is that for young people, the absolute, yeah, great answer there. So the BMI is absolute, and with young people, you know, there's not a set kind of healthy unhealthy BMIs. It changes as they grow, and so median BMI is relative, and this is what you'll find on your junior marzipan guidance as well. So you'll find on their categories based on your on BMI. So would everyone like to have a go using those formulas on there, just calculating the median BMI and pop in the answer in the chat bar? Got any answers there? Yeah, thank you, Catherine. You are correct. So that's below 85%, so it's worrying. So that's an important bit of information in the first step of your risk assessment. Okay. So when we're thinking about anorexia, I think a lot of the time our focus is on risk of refeeding, which is important, and I will get to that. But we also need to think about the signs and symptoms that you see in starvation. And so the physiological process that's going on here is that in starvation, when you've got consistently reduced intake compared to your energy output, you're going to see an increase in protein and fat catabolism. This results in loss of cellular volume and function and results in atrophy. And this atrophy affects all parts of the body. So you will see atrophy of the heart, which is why you get some of the signs and symptoms that we're going to discuss, of the brain, of the kidneys, of the liver, of the intestine, of the muscles, and these all result in signs and symptoms that you're going to want to discuss. Yeah, lovely. So so some of those have been highlighted there. So yes, so syncope is a really common symptom, or syncope or pre-syncope in young people who are starving. You can get swollen ankles of a variety of different different reasons for this. You do get bradycardia and with a postural tachycardia often. The lanugo hair is the fine hair that develops, but you also might get areas of skin breakdown, thinning of hair, brittle hair. One important symptom that I was not so aware of is if you think about the gut's got a lot of muscle there, and so when someone's starving and that muscle is reduced, you can get a lot of gastrointestinal symptoms. So the feeling of kind of fullness that young people will describe, it's very real. Their bowels are going to be moving much slower than previous, and this will cause abdominal pain, feelings of fullness, and feelings of bloating, all of which it's important to kind of to recognise, work out whether there's something more serious going on, but also educating a young person as to why that's the case. And then if we think about our hormonal symptoms, so particularly amenorrhea is a symptom that you're going to want to ask about. So here are some of the life-threatening complications that you can get from starvation. So, and what are the treatments for them? So if you've got severe bradycardia, and it's really in relation to the junior marzipan guidance that we would test them. I don't know the numbers off the top of my head without looking, so I always get that risk assessment out in terms of thinking about the degree of bradycardia and postural tachycardia that is concerning. As you can see, the treatment for all of these things is nutrition. Prolonged QT can potentially result in arrhythmias that could potentially be fatal. So when you've got these signs, a young person needs to be monitored really closely, and you need to kind of correct all those things that are correctable, but ultimately it's going to be nutrition that's going to make things better. Fluid balance is a really important consideration, something to ask about in your history. Because not only can young people restrict food, but they may also restrict fluid. But we also need to recognise that if a young person is showing signs of hypovolemia, they may be in a state where actually they're not going to show the typical signs of sepsis, and they're vulnerable to infection. So this also needs to be thought about. So those are the kind of the more life-threatening complications. So your physical examination. So for your cardiovascular system, you're going to want to listen to the heart, do lying and standing blood pressure and heart rate, and also just to reiterate, it's lying and standing blood pressure and lying and standing heart rate, because postural tachycardia is a key sign that you're going to look for. You're going to look at the hydration status. Have we got a low temperature? And then this picture here is a demonstration of how to do the SUS test, which helps to demonstrate kind of muscle strength or lack thereof. And I quite like these pictures because it makes it nice and straightforward for you to understand what exactly is happening there. In terms of investigations, what investigations do you think are important? If we think about both assessing for risks and also potential other causes. Yeah, so ECG, absolutely vital. Electrolytes, yep, and including a bone panel in that. Full blood count, yes, definitely. And one of the signs that we can see in the blood is, so we might see signs of anemia, potentially even severe anemia requiring transfusion. You might also see low white cell counts, which is another marker of starvation. Lovely. Magnesium phosphate, yes. You're going to want to do your liver function tests because you can see sort of transaminitis either associated with starvation or also associated with refeeding. And then any ideas about things that you can kind of fairly quickly rule out on blood tests, some of the other conditions that are easy to rule out that we talked about, and potential differentials for a young person with low weight and reduced appetite. So yeah, thyroid function and a celiac screen. Yeah, lovely. Fab. So ECG and calculating the corrected QT interval is important. Your biochemistry, including your urea electrolytes, but also your magnesium, calcium, phosphate, LFTs. Blood sugar can be important, so you can see young people with hypoglycemia as a result of starvation. And then your full blood count and a film can give you an idea about the other worrying diagnosis that we didn't want to miss, which is leukemia, and your CFTs and TCG, again, important to rule out on a first presentation. And then if you've got amenorrhea, you want to have a think about, is there any other reasons why that might be present, and having a look at ferritin, B12 and folate are all recommended in junior marzipan. So what I would say is, before going, if this is not something that you do routinely, I would recommend having a look at the right page in junior marzipan before you go and examine someone, just to make sure that you're having a look at all those parameters, and then you can have a look and that you can compare and risk assess based on your findings. So for Lorraine, we've got her mean percentage BMI, which is 75%. She's got a postural drop of 15 in her systolic blood pressure, and her heart rate a significant increase, a significant postural tachycardia. Hydration, and she hadn't really been drinking very well, but she is on IV fluid with her NAC now. Temperature is just borderline low, but we wouldn't give you a score on marzipan. A SUS test of 1, so she can get up from lying down and stand up from squatting, but this is with difficulty. QTC is on the borderline, and she's got a low white blood cell count. So putting those together, she scores in the amber range if we look at the junior marzipan guidelines. And one thing that I would, one tool that I would recommend, and it's highlighted in the learning pack for this week, is that the Healthy London Partnership and Paediatric Critical Care e-learning has a e-learning section on anorexia, what that includes is, it includes lots of case studies where you can practice scoring different parameters on your on the junior marzipan guidelines. It also covers some of the life-threatening complications that we briefly discussed in more detail, and it includes lots of information about about how and when to to use the Mental Health Act, under what legal powers you might be able to treat a young person with anorexia that I'm not going to have time to cover today. So it's in the learning pack, which you can access online. The link there, and you just have to register, but anyone at a London hospital can register. So if you want more practice at this stuff, then I think that's a really good interactive way to do it. Because it's, unless you're kind of practically actually doing it, it's difficult to feel entirely comfortable with it. But I think that's really the best approach if you want to learn more. Okay, so we thought about her risk in terms of her physical health risks, in terms of her state of starvation. But what about the other risks? So Lorraine has a really obvious other risk in that her health is very severely compromised right now because of the paracetamol overdose. But there are other ways that a young person might be at risk. And so even if they were scoring green on your junior marzipan guidelines, you wouldn't want to send them home. So a young person in any mental health crisis can be extremely stressful for families. And if you've got a family at breaking point that does not have the resource to be able to turn things around at home, then that's a significant risk. You know, you might have a young person in whom you've identified that the trigger for their deteriorating mental health has been sexual exploitation. There are many other risks. So I think it's important to consider those physical risks, but also we have to put that together with our social, environmental, psychological risks as well. So it's not a kind of the traffic light system in marzipan is really it's thinking about your physical risk and the risk specific to an eating disorder, but we also need to think about all our other risks for a young person. And we also need to think about protective and motivating factors. And you may well have got this from your heads assessment and from your kind of conversation with parents. So if you've got a young person who is physically compromised, but actually you've got a very motivated and well-resourced parent who has a good relationship with their young person, and you've got a young person who actually is really motivated to achieve something like getting back to school, for example, this can all be really helpful. So you have to view things as a whole, and that's how your heads assessment really comes in useful. Right. So next we need to think about refeeding syndrome. So refeeding syndrome is a risk for young people who have been starving. And it happens in not just in anorexia, but in other states we need to think about it, other like disease states where nutrition has been compromised. So the process is that when you've got malnutrition and you've got that breakdown of protein and fat, you've reduced insulin, increased glucagon, and then when you start to refeed, start to give carbohydrate as a main energy source, you get an increase in insulin secretion. And what this does is it leads to increased sodium retention, increased glucose uptake, increased thiamine use, and then an intracellular shift of phosphate, magnesium, and potassium, which can result in levels plummeting and the young person becoming very unwell with all the signs and symptoms that you can get from those electrolyte abnormalities. So how you manage this is thinking about the risk level of the young person and also monitoring them. You might need to slowly refeed them. So if someone's at very high risk, you're not going to want to give them too much carbohydrate to start with, to try and avoid them tipping into refeeding syndrome. And how you do that is all very nicely outlined on your junior marzipan guidelines. So this is a little excerpt from it. So a high risk patient would have some or all of these features, and it's a little bit of a judgment call because some young people will flip between the two kind of boxes, but so you're looking kind of overall at the picture to determine whether they're high risk, moderate risk, or low risk. So it's fairly self-explanatory, but depending on the risk level will depend on your management plan. So at St George's, we're very, very lucky because we have really nice, very self-explanatory guidelines for how we manage young people depending on their risk level, including these detailed meal plans that you can see on the right side of your screen. These are all taken from Junior Marzipan, and the only thing that's been developed, I think, separately is the meal plan, but essentially follows the kind of follows the principle of like the calories that you can see there. So if a young person's at high risk of refeeding, then you are going to want to monitor them more closely. You're going to want to start feeding slower, and you're going to want to give them thiamine, because they're going to have that increased use of thiamine, and you want to avoid thiamine deficiency. Where young people have significant cardiovascular compromise, or they are very low weight and they're very unwell, if they're fitting more into the red group, then you're going to want to instigate bed rest, which can be, young people can find really quite restrictive. So it's so important to explain to them exactly why you're doing that. And so you're doing that because you want to switch off metabolism, and you don't want to put strain on their heart that's been compromised. So that's really key to explain that and explain what that means for a young person. And then basically, as the young person progresses, you may be able to switch onto the different plans as you go through. And again, this is all in Junior Marzipan. And how we would manage this on the ward in terms of some of the practicalities of it. So generally speaking, we'll try and give, if it's safe, we'll try and give a young person sort of 24 hours or so to see how they get on with their meal plan before thinking about starting NG feeding. But obviously you have to balance, it's balancing risks, and every young person is different. Depending on the stage of treatment that the young person's at and how things are within the family, it might be that actually you're asking staff, so nursing staff, healthcare assistants, or an RMN to support the meal times and taking the parents out of the equation. But more often, especially for young people who have a diagnosis and have been working with the community eating disorders service, you're going to want parents to be there to support the meals, because that's what's going to happen in the community. And I'll move on to a little bit about how that works in the community, so how the management works and how the eating disorders team assesses and manages patients. So you can imagine actually that trying to get a young person who you've just met, trying to find the right way to support them with something that they potentially find really, really difficult, like eating, is really quite a skilled job. And it can be really quite time consuming and potentially sort of draining for the nursing staff who have to do it, particularly if they don't have expertise in this area. So one of the great things that we have at St George's is that we have some nursing staff and healthcare assistants that have been on secondment to the eating disorders unit and have learned some of those tips and tricks, those kind of additional skills that are so useful in this situation. And if you're kind of interested in how that came to be on a general paediatric ward, then within the learning pack there's some information about how that kind of close link and those processes came about. The other thing, and I don't want to sort of be patronising, but young people often pick up on young people with mental health problems who end up admitted to paediatric wards often feel like they are in the wrong place, like they're not wanted, and that might be because of actions of staff, but it might be because of their own beliefs. But it's really important to let young people know that their needs are important, and that you're there for them, because they often kind of pick up on that, particularly with young people who maybe have a longer admission because they're waiting for an inpatient psychiatric bed. Just thinking about all those principles of compassionate care that you're all going to be really good at once you've done the We Can Talk training, just to keep that in mind and keep them in mind. So what happened next for Lorraine? So her paracetamol overdose was managed. She was assessed by the CAMHS team, and she went home with a plan for assessment in the eating disorders service, but with ongoing assessment from the and input from the adolescent CAMHS team. But unfortunately, while she was waiting for that assessment, but while still having input, she came back in with acute refusal of eating anything. So she ended up back in hospital and needed medical stabilisation at that point. And so she ended up staying in hospital and was then seen and assessed by the eating disorders team. Needed to have some NG feeding for weight restoration, but eventually ended up referred for an inpatient admission. Now, I think the kind of how this progressed and the reason for this at presentation, her level of withdrawal was really significant, and when young people get to that point, it can be really difficult to bring them round. So it's important just to, if you have these worries about a young person, to try and get that help early. So really recognising when this could be part of a bigger picture, and working really closely with your CAMHS team is really important. So I guess, all right. So I think just briefly, before I move on to talking about the role of the community eating disorders team, does anyone have any questions about the role of a paediatric ward in admission for eating disorders?
Hi, thank you very much, Emma. I have a question. In my hospital where I work, we don't routinely prescribe thiamine for these patients. Is it a routine at your working place?
So it's routine for high risk. So if they're high risk, if they fall into the high risk, that is part of our prescribing set, not for amber risk, not for green, but just for the high risk ones. But that may be something that changes. I know there's new junior marzipan guidelines coming out fairly soon.
Okay, thank you.
No problem. And I guess just one other thing to point out while people are thinking about kind of questions and things is, so what we do at St George's is we aim for an admission, not for weight restoration, but for medical stabilisation before then aiming to discharge the young person back to the community. And having a short admission for medical stabilisation can potentially have lots of benefits for young people. Often when young people need inpatient admission for an eating disorder, there's no local bed, so a young person can be moved really far away from their family, far away from education settings, far away from those things which are protective and motivating for them. So if you can, in that acute phase, really optimize their nutrition, so they're in a medically safe place for them to work with the community eating disorders team and avoid inpatient admission, that can be really beneficial for young people. So I think that as a paediatric ward and paediatricians, we have such an important role to play for young people, and making those 10 days, these kind of 10-day admissions really count. Working really closely with the eating disorders team can make a huge difference for young people. Fab. Any other questions just before I talk about the role of the community eating disorders team? Fab. Great. So what does the community eating disorders team look like, and what do they do? So a community eating disorders team is made up of psychiatrists, psychologists, nurse specialists, and there's a dietitian. So a big multidisciplinary team, and their role is to assess and treat eating disorders. So in the assessment process, what they're trying to determine is, is this a diagnosable eating disorder? Does it fit the criteria? Or is this an eating problem that is it within another kind of primary mental health diagnosis? So for example, the community eating disorders team wouldn't treat someone whose main problem was not an eating disorder. So if they had depression and that was felt to be the reason behind their low weight and their reduced appetite, that would not be managed. It's only eating disorders that the eating disorders team manage. So once the young person's been assessed, and this is a multidisciplinary assessment that takes place, seeing the young person and their family as ideally as a whole, both separately and together, thinking about a really sort of detailed mental health history and a history of how the problems arose. The team will formulate a diagnosis and feed that back to the young person and their family. The young person will have a physical assessment at that appointment or close to that appointment, to determine their physical risk if they've kind of not been seen by a professional, and the GP would do you know, the basic bloods that we talked about in young people who are not in need of a hospital admission. And then what they would do is, in young people who have an eating disorder, they would have a case manager allocated, and they would start to work with that case manager, who could be a nurse, a psychologist, a psychiatrist, and depending on the needs of that young person. Then what will happen is the treatment for eating disorders, and the evidence-based treatment that's got the best results is family therapy for anorexia nervosa. So what that looks like in the first stage of treatment is thinking about how the family can support the young person to eat. at the stage when young people are diagnosed with the eating disorder, when they're at a low weight, they don't have the resources to really be able to potentially engage with therapy in a meaningful way. So the goal of the initial goal of the first part of treatment is to think about the quite practical stuff about how a family might support a young person to be able to eat. So this will involve, for example, we've got a 17-year-old who organises most of their own meals, is out of the house most of the time. And actually, parents taking a step back, they may have kind of significant work commitments, be traveling a lot, etc. And that parent and those parents and that family have to become responsible for everything that young person eats. So making sure that they're there for meal times, that they're preparing food, and that actually choice is taken away from the young person in that instant while they get better. And this can understandably bring about kind of lots of conflict and difficulties for the family, but making sure that young person's weight is restored, and particularly kind of in the initial phases, can really help the young person progress towards recovery. So that's the kind of the model of treatment that is delivered. And kind of by week 4 of the treatment program, if a young person's managed to gain weight by that point, gain a couple of kilos by that point, then the prognosis for them in terms of their overall recovery from the eating disorder is really quite good. And where there are kind of difficulties, or where actually things are not going well, at that point you might think about more intensification of treatment, so more intensive community treatment, day case treatment, or inpatient admission if there were significant concerns. So that's kind of what's going on outside of the hospital. So you can imagine if a young person's already working with an eating disorders team, then if they're coming into hospital because of physical compromise, actually what you might want is for the family to continue to develop and up their skills in helping to support the young person to eat whilst they're in hospital, rather than breaking for that. But it really will depend on the individual young person and how things have been at home. But yes, that's essentially how what the community eating disorders team does and how they work. Did anyone have any questions about that aspect?
I have a quick question, Emma.
Yeah.
I'm really interested in the idea of family therapy. I didn't realise that was such a commonly used tool. That sounds fascinating. Do you know if much group work is done, or can that be sort of paradoxically harmful?
Yeah, so there's a parents group, and the parents group is very helpful to families. So I've sat in on a few of those sessions, and just I think for the parents, knowing they've often had to give up their jobs for a significant period of time to manage their previously independent teenager. And just knowing that someone else is experiencing this and that they're having difficulties and getting tips from other parents as to how they've managed things like meal times is really helpful. And there isn't group interventions within the eating disorders service for young people, and there is this worry. I think within eating, there may be some group work within the inpatient setting, but one of the things that you can notice, for example, when you've got a couple of young people with eating disorders on the ward, is this feeling that you're not good enough, you're not sick enough. So that can potentially be harmful, that comparing yourself to another young person with an eating disorder. So really the focus is on the family and the parents having the support of the parent group in the initial phases as well.
Thank you.
No problem. So homework for everyone, the junior marzipan guideline, just whenever you see a young person and you're thinking, could this be an eating disorder, or you're worried about, even if you're just worried about a low weight for another reason, then this is such a helpful tool in risk assessing them when they are at the point when they first come in, and then also assessing their risk of refeeding. And it's kind of bulky, but if you get to the kind of tables with the risk assessment bits in it, it's not too bad, I promise. We're very lucky at St George's because our wonderful consultant has managed to kind of adapt it so it's really user friendly, and I think Junior Marzipan could potentially be a little bit user friendly, but if you just find the tables within that, that's going to really help you. Fab. Any more questions from anyone before we finish? Lovely. Well, thank you so much for joining on this lovely sunny lunchtime. I'd really appreciate if you could fill in the feedback form. Yeah, there's a couple of the references that I mentioned. So the Healthy London Partnership, critical care outreach, e-learning, with those kind of Junior Marzipan risk assessments that you can work through. So check those out. And then if you're interested in how can I make my service, or what can we do in my hospital to manage eating disorders better, then there's an interview with Dr. Etheridge, who's my consultant, who's did a great job of really getting the service set up. So it works really well at St George's. We will put the, oh, there we go. Catherine has beat me to it. She's popped the link for the feedback just there. If you've logged into other sessions and you've missed the feedback link, then it's the same link for everything. You just pop it in there and write which talk you're reviewing. So thanks very much. Yeah. So yeah, and we can talk. I just want to highlight that because I just think it's wonderful. And that's the Healthy London Partnership one, so I can just pop that in. I can pop that in the thing in a second as well if people would like that. Lovely. And the talk yesterday will be available on YouTube, but it's not yet. So if you give us till next week, it should be available. Fab, thank you.